Welcome back, everyone, to another brand new episode of the Preventive Medicine Podcast. I hope you all have been enjoying the new episodes that have been coming to you, speaking to true experts on topics that they are really good at and bringing you some great value and some insights into different things related to preventive medicine. This is going to be the first episode of this kind of resurgence or renewal of this show where I'm just going to be talking here as far as a host. For those of you who all don't know, my name is Dr. Ragav Sharma. I'm a physical medicine rehabilitation physician who specializes in interventional spine and musculoskeletal medicine. However, I do really enjoy resistance training and have at some point had a certified strength and conditioning specialist certification and pretty much counsel all my patients to do some sort of resistance training or activity and exercise and whatnot. So I figured this was a great time to reintroduce this topic and to talk to you all about it as far as resistance training goes. And this is actually a grand rounds that I gave at my residency. And I've actually given essentially nationwide at this point. I spoke at a conference on this topic as well, a little bit more geared towards physicians as far as the entire presentations. But I figured that is missing from the podcast of really an in-depth dive into specifically resistance training, because there's just so much to it that I've kind of touched on in previous episodes and some guests have kind of talked about it, but we really haven't done a deep dive. So I figured now is the time and let's do it.
Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live.
And now, here's the show.
All right, let's get into this show. And this presentation was entitled Bringing Barbells to the Bedside. And the entire idea of this is not just taking resistance training and put it to just the gym as far as people who are just trying to get swole, but really to apply it to everyone, to bring it to patients, to make it much more widely accepted to be used as a medical intervention, aside from just using medications, injections, and things like that. And I'm not saying that this is a replacement for those things. I'm just saying that this is kind of the basis that we do a lot of these things on. And we'll talk about that as we go on. So the number one thing is kind of what is resistance training? And there are a variety of different definitions of what resistance training is, but generally it involves a contraction of skeletal muscles against some sort of external resistance with the goal of improving muscular strength and size. There's a bunch of different forms of this. And then there's body weight, which is the over normal muscular force. So something more than your body weight. There's bands, machines, kettlebells, dumbbells, barbells. The list goes on and on. The idea is that it is external resistance to your body. Now, there's a bunch of different sports related to resistance exercise. And this picture here is of Eddie Cohn, who's the greatest powerlifter of all time. And there's powerlifting, which is straight up just lifting weights. There's weightlifting, which is kind of more of a test of power versus brute strength. There's strongman, bodybuilding, lots of other things. And resistance training is a very important part of training for essentially every single sport. And this is split up to out of season and in season, where out of season, people are focused on pushing strength and size, depending on the sport specific kind of needs. And then in season, it's more very sport specific to kind of maintain that musculature and strength and staying away from injuries and overuse. Recreational training wise, this doesn't mean that if you're doing resistance training, you have to look like Arnold here. It's not just for athletes and those who are trying to be big bodybuilders. These benefits are really for everyone in improving muscular strength and size. And there's so many other benefits outside of just those two in aesthetics and sports. It does not mean you have to become a bodybuilder. And this is actually something that I counsel pretty much all of my patients on at some point. I work in a clinic, and my career as a physician is essentially musculoskeletal health. So I have a lot of patients who come to me with a variety of injuries, aches, pains, and those kinds of things. And I don't just jump always straight to medications and injections. My approach to patient care is I kind of talk about building a house or kind of like a pyramid of treatment. And the base of that is always exercise or some sort of activity. And it depends on the patient of what they can do, which we'll talk about a little bit here as far as finding entry. But the basis is some sort of activity, some kind of movement, because the goal of all of this is to remain as functional as possible and to remain as mobile as possible so you can get around and do what you want to be doing. So now, what are the specific benefits of resistance training? And like I talked about, there's way more to it than just what meets the eye, literally, as far as looks and aesthetics. These benefits go from general body composition to bone health, cardiovascular health, metabolic health, mental health, general frailty, and then morbidity and mortality. And we're going to dive into each of these in specifics. Like I said, this podcast can get a little bit granular here, so bear with me. I promise you there's a lot more applicable stuff coming in a little bit, but you have to hear these benefits because some of them might actually shock you. Body composition wise, I think we all know that this will help decrease your fat-free mass or increase fat-free mass and reduce your fat mass. So this is adequately dosed resistance training, does all this, including reducing your visceral body fat. And then it can also help retain fat-free mass when you're trying to lose weight for patients that are trying to aim to reach a healthier body weight. So if you are on one of these weight loss drugs and you're trying to significantly reduce your body fat for a health goal, adding in resistance training helps you maintain that muscle mass so that you're not really losing out too much on that fat-free mass. What is the big deal about fat-free mass? Generally, it's protective against overall mortality and provides prognostic information on mortality risk that's not given by things such as BMI. So this means if you have a high fat-free mass, but also have a high BMI, that high fat-free mass is protective despite you having probably a little bit more fat mass on you from the BMI. And then also in older adults, it improves appetite and energy, which can be a huge issue. A lot of you who are listening might not kind of think that as a huge issue, but when we get older, it gets really hard to eat. In some of my older patients, kind of what we have to force them to do is eat because they're just not eating enough to maintain themselves. Bone health is one of the most obvious kind of benefits of this. And here is a little kind of graph that shows, and those of you who are listening to this podcast, there's also a YouTube version of this where I have my slideshow that I used for this grand rounds. So if you're not already, hop on over there. There's a whole bunch going on these slides that you should check out. So go do that. Bone health wise, bone density generally peaks between 25 and 30 years old, and bone loss typically starts around 40 years old and affects women more than men. And this is due to estrogen and a variety of different hormones that have those effects. And this osteogenic effect, in other words, growing bones, requires some sort of mechanical loading. Now, when it comes to loading bones, walking has little to no loading effect on bones and thus does not slow down any sort of bone loss. People say, oh yeah, I do exercise, I go and walk this much. That's not going to do anything for osteopenia or osteoporosis or to help build that peak bone mass. This is where resistance training comes in because you need some sort of compression, tension, shear, whatever the mechanical loading is to help increase that kind of force on the bones to help them grow. And when you have a lot of the risk, 60% of the risk of developing osteoporosis is explained by peak bone mass. So in other words, the higher that your peak is, the lower your risk of developing osteoporosis because everyone will have a decline in their bone mineral density at some point. It's just kind of how high you get that peak. And you want to do that as early as you can in adulthood. And that's why you should load your bones. And there's a bunch of different articles out there for doing this in adolescence and whatnot. And there's a great article out of the Korean Society for Bone and Mineral Research that you should check out if you're on the YouTube version. As far as fighting osteoporosis and fractures, there is direct evidence and indirect evidence and indirect kind of technique or mannerisms that resistance training helps. And it's this kind of little graph here. So you have resistance training that directly combats osteoporosis through the osteogenic mechanical loading effect, but then also it can help things like increasing your muscle mass, increasing or decreasing your ability or risk of falling. It can help a variety of different things that are kind of seen here in this little graph. So rather than being fearful of loading your bones after osteoporosis, which a lot of people are because they're afraid of a fracture, it should be encouraged, barring other contraindications. And there's a really interesting study that's coming on later in this presentation that I want you to keep an eye out for regarding this fact right here. Cardiovascular health. Typically, we don't think of resistance training as being that good for cardiovascular health. We think of aerobics. We think of going out for a run. We think of these people who are kind of triathletes who are doing a ton of biking, those kinds of things. However, this isn't necessarily the entire truth. Any amount of resistance training does reduce cardiovascular mortality by 19% independent of aerobic exercise. On cardiovascular markers, it reduces total cholesterol, LDL, triglycerides, and waist circumference, and also increases HDL. It reduces blood pressure. It improves peak VO2 in 6-minute walk test in those who have heart failure. So it's not going to do a whole bunch if someone's really trained, but for those who are not doing anything at all, if they have heart failure, they can't do any sort of aerobic exercise, then resistance training does help as far as some aerobics goes. However, I want to caveat all that saying you don't have to skip the cardio and just say, hey, I can just do resistance training. I'll do the same thing. That's not what I'm saying. the combined effect of both of them, resistance training and aerobic exercise, is still much greater than that of resistance training alone. The entire point of this slide is just to show that there is some effect on cardiovascular health, and it's not completely a waste. Metabolic health, this is a huge one here. And this is really that resistance training increases insulin sensitivity. And it does this through some very specific mechanisms, such as increasing the upregulation of a receptor called GLUT4, which helps glucose absorption into cells. And then when you look into specific diseases, it reduces hemoglobin A1C in those with type 2 diabetes and type 1 diabetes. And it's once again, this effect is increased with aerobic exercise as well. So exercise is great for metabolic health in general. Now we come to mental health. So a lot of times when we think of exercise, resistance training, aerobic exercise, we think of the physical manifestations of this. However, there's also psychological manifestations as far as helping with anxiety. So resistance training has been shown to significantly improve symptoms of anxiety in those with or without mental illness. And then this is also further stratified into reducing symptoms of anxiety in young adults without a diagnosed anxiety disorder. And then compared to aerobic exercise, it was actually more effective in the treatment of anxiety disorder. So all in all, that shows you that resistance training both prevents and treats symptoms of anxiety. When it comes to depression, very, very similar. Resistance training significantly reduces depressive symptoms in adults and adolescents, regardless of health, amount of resistance training, and improvements of strength. So this is saying that it's not like if you get significantly stronger or if you gain a significant amount of muscle mass or strength or whatnot, you're going to feel better about yourself. This is just saying actively participating in kind of the activity of resistance training will significantly reduce depressive symptoms. And then once again, resistance training alone has similar effectiveness to aerobic exercise or mixed exercise for the treatment and prevention in young individuals. So once again, very powerful. Now, when it comes to pain, this is something that is very close to what I do on a day-to-day basis, because for the vast majority of people who are coming to me, they're in some sort of pain. So patients with pain, not due to specific trauma, typically shy away from exercise because they feel like it hurts and it's going to worsen the pain. However, this is quite the opposite, as resistance training decreases pain intensity in chronic and non-specific low back pain, reduces pain, stiffness, and improves physical function in those with knee arthritis, and then also reduces pain, fatigue, the number of tender points, increases functional capacity and quality of life in patient with fibromyalgia. So just because someone's in pain, and I'm not saying this is excruciating pain if they're 10 out of 10, something's going wrong, they have an infected joint. This is not for those patients. This is those for kind of generalized pain, ranging probably like a 3 to a 6, maybe a 7. This isn't something you should shy away from just because you're in pain. Resistance training can be beneficial for those even in pain. Now, frailty. A lot of us listening to this podcast, unless you're starting to get up there in age, are not necessarily thinking about frailty as kind of an issue. And per the American Academy of Family Practice, frailty is typically for those who are geriatric with age-associated declines in physiologic reserve and vulnerability to internal and external stressors. So essentially, you've kind of been right at that line where you have one thing that knocks you, and then all of a sudden you're having a bad time. So this is evaluated formally through things like gait speed, weight loss, grip strength, physical exhaustion, and graded into non-frail, pre-frail, and frail. And adults, as they age, inactive adults lose between 3 to 8% of muscle mass per decade, with most of that happening between the ages of 50 and 80, leading to sarcopenia, which is a risk factor for frailty. Obviously, resistance training combats that by increasing muscle size and strength, and can be done throughout the lifespan. And then directly on these tests of frailty, resistance training improves pretty much all of them. So resistance training directly combats frailty and makes people a little bit more durable, which if you are not following me on Instagram, I have a post kind of on durability. So go check that out as well. Now, the big thing, overall morbidity and mortality. So this is your overall kind of rating of being sick or your overall chances of dying. That's what mortality is. And now if you look at the data, this is actually pretty stark. Any amount of resistance training reduces all-cause mortality by 15% with a nonlinear relationship and a maximum risk reduction of 27% with 60 minutes per week. I want you to hear that again. Maximum risk reduction of 27% with 60 minutes per week. Now, A lot of us out there, a lot of us gym rats and whatnot are there for pretty much 60 minutes a day, like 3 to 4 times a week, maybe even more than that. But we're not necessarily getting any more risk reduction as far as all-cause mortality. It's 27% with 60 minutes per week. So that means if you are just going like twice a week, once a week for an hour even, you are getting the maximum effect out of resistance training. And that's not to put people down if they're doing a lot more than that. We might have other goals, but this is as far as the maximum benefit you are going to get is from 60 minutes per week, which means it's actually pretty a manageable thing to achieve to get to that kind of level. When you look at longitudinal studies, a 15-year cohort study using the National Health Interview Study found that older adults adhering to recommended resistance training guidelines had a 46% lower odds of all-cause mortality than those who did not. And this is stratified in other studies. If there's the two parts of the resistance training guidelines, which are the resistance training and the aerobic separately, if they did both of them, it was 40%. If they did aerobic only, it was 29%, and resistance training only 11%. All in all, to show is that there is a significant reduction in all-cause mortality for those who exercise, and in this case, specifically do some sort of resistance training. Now, that was a lot of information. If you are listening to this on a mobile player while you're driving or something, you didn't catch something, feel free to rewind back and go through it. If you are on the video version of this, then there's a nice little table here for you that's showing you kind of all of the benefits overview when it comes to body composition, skeletal health, cardiovascular health, metabolic health, mental health, frailty/pain, and general morbidity and mortality. All in all, if I can summarize it, it is 2 thumbs up. If this is something that we could bottle up, put in a medication, and give to every patient, it would be tremendous. It would be a blockbuster medication. Unfortunately, it's not that easy. Now, the question is, if it's so beneficial, how come we're not doing it? How come everyone's not doing it? Why is it so difficult to get people to do this despite so many benefits? And this is shown in the data that not that many people are doing this, where if you look at the exercise participation out there, 8 of 10 adults do not meet the general physical activity guidelines set by the World Health Organization. And just as a brief refresher for those who are not aware, who have not listened to this podcast before, and thank you if this is your first time, there are 2 parts to it. The first part is aerobic exercise, which is 150 minutes a week of moderate intensity aerobic activity or 75 of vigorous intensity per week. And the second part is 2 or more days of resistance training per week involving major muscle groups. So those are the 2 parts. And those who are at lower odds of meeting are unfortunately those of lower socioeconomic status, poor self-rated health, women, those who are obese and underweight, older adults, and current smokers. And that was 8 out of 10 do not meet both of them. And then if you look at resistance training specifically, this is even lower. So there's a lot of variability, but it seems like only 10% adhere to that guideline, which is fairly low. And if you look at people who do just the aerobic portion, it's about 50% of people who meet that. So many more people are doing aerobic exercise than resistance training, which is amazing because it's amazing that people are exercising in general. However, there's so many benefits of resistance training that the vast majority of people, 90% of people according to this, are missing out on. Why? There's a whole bunch of barriers out there. The CDC actually has, I guess when they were credible, they had a whole list out there, which was a lack of time, social support, lack of energy, lack of motivation, fear of injury, which we'll dive on, lack of skill, lack of facility, and high cost, and also weather conditions. Obviously, there's a ton of these dependent on the specific population. And I'm not going to dive specifically too much into the specific barriers for this, but for the most part, there's still a lot of stigma out there. There's a lot of kind of variety in prescription of resistance training. And one thing I do want to point out on the slide, and for those of you who are listening, is that in a survey of physical therapists and physical therapy students, and we would think of physical therapists as those who kind of know how to exercise, who know how to get patients to start exercising, 90% prescribed resistance training, but only over 48% reported that their education did not prepare them to apply it, and 68% believed it was inadequately applied. So they're all kind of talking about it, but don't really get taught how to do it, which is unfortunately an error in kind of our system of musculoskeletal health. And then for physicians, the reason we don't talk about it a lot is, once again, we also don't get taught very well on it. And there's a lot of ambiguity around prescription of exercise, which is the biggest barrier. Now, there's a whole bunch of other literatures, a bunch of gaps that are not in the literature, and that's something that is tough to explain. Like I said, there's a lot of things such as stigma and a variety of other things, but it's difficult to quantify that, so that's not something I'm necessarily going to talk about today. However, the one thing I do want to talk about quite a bit that's not necessarily evidence-based or literature-based is a bunch of narratives and dogmas that arise as barriers. And kind of the big part of this podcast here, and this is kind of the meat and potatoes of this episode that I really, really want to dive into, and a big barrier for people is this narrative and dogma. Now, there's not necessarily literature saying that these are the biggest barriers, but from my time being around a gym, being a trainer, helping people reach their goals, I've seen these as kind of barriers throughout the fitness space. So you'll, even within the medical space, you'll hear physicians say this, you'll hear a lot of medical professionals say this. It's things like squatting puts a lot of load on your knees and back. You could injure yourself, so you shouldn't squat. People will say deadlifting is terrible for your back. You're going to herniate a disc. Oh no. And then people say it's not a question of if, it's a question of when you'll injure yourself from lifting. People also say if you don't use proper form, you're not going to get any of the benefit and you're just going to hurt yourself. And the list goes on and on. If you're listening to this podcast, you've probably heard someone say this, or you've probably heard this being out there as kind of things that people say. And especially, unfortunately, from medical professionals, which is one of the reasons that I actually made this presentation way back when in residency, because I was just tired of hearing this from people around. So I was like, hey, there's evidence that's contrary to all this, so let's make a presentation on it. So what do we do about this? And this is a little homage to Barbell Medicine and Austin, specifically from Barbell Medicine, who we've had on the show, who has tremendous content out there, and Barbell Medicine specifically. So if you have not listened to our episodes with them, go do that. And then also go check out Barbell Medicine as well. I absolutely love what they do, but they say what do a lot. So the biggest thing that we should do as healthcare providers, specifically physicians, like I said, this presentation was geared a little bit more towards physicians, is we should avoid nocebo. And we should suggest a general exercise program, home exercise program that includes resistance training. We should provide reassurance for continuing that resistance training. We should dispel myths regarding the safety of resistance training. And once again, avoid the nocebo effect. And for those who are listening who do not know what the nocebo effect is, it's essentially a situation where a negative outcome occurs due to a belief that the intervention will cause harm. Does that sound familiar to you? Does that sound like you shouldn't squat because your knees are going to hurt and you're going to herniate a disc? Yeah. So if you say that, people won't squat, and then you're in a negative outcome because you're not squatting, you're not reaping all the benefits. And in this case, the negative outcome is that the patient or person does not participate in resistance training. So this is where also, if you're watching this on YouTube, once again, we have the Mythbusters, Adam and Jamie up here, because that is what we're going to do. We are going to bust some myths. The first myth, I am going to get hurt. You hear this a lot, not necessarily from gym rats or people who are younger who are going a lot, but you hear this a lot from patients in the clinic. Because if you tell them someone's coming in with knee pain, hey, you should go squat, you should go strengthen your quads, they're going to think if I squat, my knees are going to get worse. And this often leads to negative thoughts and is perceived as risky when actually it's quite the contrary. If you look at the incidence of injury, it's 0.31 and 0.05 per 1,000 hours of weight training for men and women respectively. So if you extrapolate all that out, it's one injury for 28 years in males and one injury per 192 years for females. And that's assuming you're doing the 2 hours per week according to the ACSM. Obviously, it goes up if you're training more than that. If your training volume is very higher, you're at a higher risk of injury. But regardless, that is incredibly low. And most of the injuries that are seen in emergency rooms from these are dropping weight. So if you drop a 45 on your toenail and it goes black and blue and you feel like you've amputated yourself, that's an injury for sure. But that's not necessarily related to the weight training. That's you drop something. All right. If you compare this to sports, we think of running as super safe. We think of all these other things, not really that injurious. There's an interesting one in here. Running has 2.5 and 33 injuries per 1,000 hours for long distance and novice runners, respectively. Basketball has a 7.97 and 6.54 per 1,000 hour risk for men and women, respectively. And golf, yes, even golf, has 8.5 per 1,000 hours in competition and 3.3 injuries per 1,000 hours in training. Yes, golf is riskier than resistance training when it comes to injuries. Golf, and that's a sport we think of old people doing. We think of it's something you can maintain the rest of your life because it's pretty chill. It has a higher rate of injuries than resistance training. And then tennis is one of the most injurious with up to 62.7 injuries per 1,000 hours in training, respectively. So there's a myth as far as you're going to injure yourself. You could, However, it's much lower risk than you would think. The next myth is I'm going to hurt my back. This is something that you hear pretty commonly, typically in relation to things like deadlifts and squatting and just heavy movements in general. And this exists for most lower body exercises, and for good reason, actually. When you look at the literature, 60% of injuries from resistance training occur in the lower back, typically with the deadlift and squat being the most commonly associated exercises. And this is more prevalent in lifters with more training hours. In other words, if you are someone who's training more frequently with heavier weights, you're at a higher risk of injury. However, there's more to the story. If you look at even more literature, when you look specifically at powerlifters, the people who I'm talking about who are lifting heavy weights for a long amount of time, there are no reports of major back injuries in the squat or deadlift in a review of injuries specifically in powerlifters. And then if you look even more granularly at people who are lifting heavy, there's a study with 154 individuals who had disc herniations and pain due to those. 67% of them had no inciting factor. They're like, I don't know where this is coming from. 26% came from daily activities such as mopping, doing chores, getting out of the car, and only 6.5% of them could say that their pain came specifically after heavy lifting. There's also no association with severity. So someone who's doing something like mopping might have a severe disc herniation and a ton of pain, where someone who's lifting super heavy weight might have just a little bit of pain with it. And then there's also no compelling evidence that lifting with a flexed back makes you more prone to lower back pain. And that's a whole other topic that I'm not going to get into today, but there is pretty convincing evidence that if you are lifting heavy, you're not necessarily going to injure your back. And in reality, it could be pretty safe. And then the knees. It always comes to the knees. And this is that loading the knees increases degeneration and stops people from resistance training. And this is, once again, a common area of injury for powerlifters and weightlifters, but it typically includes more things like tendinitis, minor strains, and cramps, which are usually due to poorly dosed training versus actually the risk of the activity that itself. And when you look at the disease of degeneration of the knees, osteoarthritis, patients with knee osteoarthritis actually benefit from resistance training with regards to pain and function. And then once again, more mechanistic things. People think if you're squatting with your knee kind of caving in like that with a knee valgus, it's thought to be injury prone. However, when you look at the literature, squatting with knee valgus does not actually increase the risk of injury. Once again, that's a whole other mechanistic topic that I'm not going to dive into, but this is kind of what the literature shows out there. Now, this is for those of you who are out there who are either older who are listening to this, or those of you who know someone who's older listening to this. And for those who have made it this far, I told you to keep an eye out for an interesting study, and this is it. It's here right now. So pay attention here. The common myth is that I'm too old to benefit. And this is for those, let's say, patients are 60s, 70s. They say that they're only going to get the risks of resistance training without any of the benefits because, hey, it's too late. And this is also people who have pre-existing comorbidities. Let's say they already have pretty bad back as far as a lot of pain from arthritis, bad knees, those kinds of things. This is a very, very interesting study here. So it's called the Lift More trial. It had 101 women aged greater than 60 with osteoporosis. So this is diagnosed osteoporosis. And they trialed 5 sets of squats and deadlifts at 85% of their 1 rep maximum for 2 times per week for 8 months. So a group did that, and then a group did low intensity exercise. For those of you out there who know, who have been training, 85% of a 1 rep is a pretty decent weight. So for me, for example, if I am deadlifting, let's say my deadlift max is 700, then 85% of that is close to 600 pounds. So it's fairly heavy still. When you look at that, there's only one adverse event in greater than 2,600 sessions, and it was just a mild low back muscle strain, which the participant was able to come back to training relatively quickly. And then overall, obviously, if you have one group doing very heavy lifting consistently versus the other not doing too much, the exercise group improved bone mass and physical function substantially over the other group. So if someone says they're too old to benefit, pull up the study because it's showing that even women with osteoporosis greater than the age of 60 were able to benefit, and it was a fairly safe exercise for them. Thus, on the contrary, it should be strongly recommended as it increases physical function and reduces frailty. Now, like I said, all this applies not just to people who are gym rats, who are young, healthy, who are trying to increase their peak of all these things. It's for people who are already kind of older, for people who already have diseases, for whatever it is. It's never too late to join and do some sort of resistance training. There's also people who say it takes too much time. And I already addressed this a little bit by saying the maximum benefit as far as morbidity and mortality is from 60 minutes per week. But people still think that it takes hours and hours of time to get any sort of benefit. They see bodybuilders in the gym spending like 2 hours a day every day. They see runners out there who are running for like 2 hours a day every day. And they say, hey, only these people can get benefit because they're putting so much time into it. This isn't true. For healthy older adults, a training frequency of 3 sessions per week, 2 to 3 sets per exercise, 7 to 9 repetitions per set was the most effective for muscular hypertrophy and strength. If you take those, that's a maximum of 9 sets of 9 repetitions per exercise per week. Assuming each repetition takes about 2 to 3 seconds, that's 4 minutes per exercise. If you pick like 4 to 5 exercises for the major muscle groups, that's 15 to 20 minutes per week. And once again, that is the most effective for muscular hypertrophy and strength. And this is in healthy older adults, 15 to 20 minutes per week. I'm going to say that again. 15 to 20 minutes per week for healthy older adults for the most effective kind of exercise scheduling for maximum muscular hypertrophy and strength. But even at that low amount, there's still evidence to suggest that even less than that can have benefit. And there's a concept now known as exercise snacking where you do even less than that. So even if you're doing 5 minutes, there's still a benefit if you're doing 5 minutes a week. There's also the notion that it's too hard to learn. And this is oftentimes coming from people who say you have to have perfect form. And this is an often reported barrier, which people think that if you don't use good form, you're just going to injure yourself and not really be able to get any of the benefit from it. And this is necessarily not true at all. This a lot of times comes from CrossFit. So if you think of people that are doing CrossFit, and sorry if you do CrossFit out there, my apologies in advance, but typically when you're doing CrossFit, you don't have the best form. You have the most irregular form a lot of times in CrossFit because the goal is just to complete whatever the objective is. And a lot of times we make jokes, or not necessarily we, but people make jokes about how CrossFit people are getting injured all the time because they do some crazy stuff out there. But if you look at the literature, it actually has the same injury risk as other lifting sports with strict form requirements. So for example, powerlifting is very strict form requirements. You have to have a certain knee angle. You have to get to a certain depth. You have to do things in a very certain way, which is thought of as good form. Whereas in CrossFit, the goal is just to get it up. So people have all kinds of forms out there, but there's the same injury risk. So it goes to show form doesn't necessarily matter that much when it comes to injury. And now when you think of free weights, they're often thought of as optimal when it comes to resistance training, because that's what you think of when you think of a gym bro or someone who's going to the gym. And they do have a small learning curve. Luckily, free weights and machine-based modalities are similar in promoting strength and hypertrophy, which means you don't have to necessarily go to the gym and use the free weights. You can just be a machine hopper and just keep going around the machines and still get some great benefit. Now, another concept that I've liked to kind of bring about to my patients is that it's perfectly okay to train dumb. You don't necessarily need to go to a gym or have some fancy equipment. You can do it with stuff you have laying around at home. So this is, for example, you can hold heavy jugs of water or a backpack and fill it with something and do squats, go up the stairs. It's external resistance that you are challenging yourself with. That counts as resistance training. If you have cinder blocks or anything else heavy in the garage, you can lift that up, boom. You're doing deadlifts. And then also renaming exercises can make them less intimidating. For example, the deadlift sounds pretty scary. Whoa, Dead's in the name, deadlift. Instead, you can just call them pickups. So you can be like, hey, go do some pickups with some cinder blocks. And that makes it a lot more approachable for some people as well. Now, what's the answer to injury risk with everything? Because it sounds like nothing you can do is going to really hurt you with resistance training is the takeaway from all this. That's not necessarily the case. The best way to prevent injury is training dose. If you are doing too much, too fast, or something that you're not prepared for, that is when you have a much higher risk of injury. So for this, I like to think of Goldilocks. Too little and you're not really doing anything to go and prepare yourself for heavier weights. And if you're doing too much at a time, you increase your injury risk. And then a moderate dose of resistance training reduces the risk of injury and pain in athletes. So essentially, you have to find that middle ground, something that's not too challenging, but something that's not too easy. If it's too easy, you're not going to train yourself to progress. But if it's too hard, you're just going to burn out and more than likely injure yourself and not be able to progress and build that resiliency. I like to think of resistance training as building resilience through movement. So you don't start as kind of a fully trained doctor. You go through the stages of preparation as an undergrad, medical student, resident, yada, yada. So you have to start at that lower level and build your way up. And you build resilience to that movement by doing it. And all in all, increase the whole host of benefits that we've talked about. Now, this portion is specifically for my physicians or practitioners who are out there. So if you are not, then either you can skip this part, or if you want to listen in and see what your doctor should be telling you, then you can kind of tune into this next part. But here we are. So the number one thing is understand your patient. Now, we always kind of do a poor job in medicine of kind of being paternalistic, of telling patients, hey, you need to do this, and not really listening to them, and that's it. So the number one thing is understand your patient, figure out where they are. And the number one question is, are they meeting the ACSM guidelines? If they are, for resistance training and aerobic exercise, you're done. You don't have to do too much more, because they're probably getting the maximum benefit out of it, and they're doing a phenomenal job. This is your time to congratulate them, to encourage them to keep doing that, and to really just congratulate them, because they are in the minority of patients doing that. If they're not meeting the guidelines, our goal is to help address those barriers, to see what we can do to help them alleviate those barriers, or refer them to someone who can, find them resources and those kinds of things. If they're not doing any sort of exercise, then sometimes it's okay to back off and just kind of say, hey, are you interested in this? Is it something we should talk about now or no? Because a lot of times patients are there for your expertise in medicine, for whatever you're there for. So they don't necessarily always want their cardiologist talking about resistance training. They want to know how their heart is doing, what medications they need to adjust, those kinds of things. So if that's the case, then that's okay. Let them be. There are other people and other times you can address this. This is kind of the trans-theoretical model of change that we have all heard of over time. And for those who are watching on YouTube, obviously you can see this. If you're listening, you can't, so I'll just describe it for you. There's a couple of different stages. There's pre-contemplation, where you have no intention of changing your behavior. Contemplation, where you're like, hey, maybe I should do something, but you're not really committed to it. Preparation, where you're like, hey, okay, I know there's a problem. I'm going to do something about it. Then there's action, where you're like, hey, I have a problem. I'm doing something about it. I'm going to fix this. This is going great. There's maintenance, where you're like, all right, this is going great. We're going to keep going. We're fixing the problem. And this is sustained change. And then there's relapse. This is, oh, I went on vacation. Now, I can't go exercise anymore because I'm just out of the habit. Then it goes back to pre-contemplation, and so on and so on. So it's important to kind of understand where people are on this to be able to address kind of their concerns and help them get back on the bandwagon. Now, like I said, unfortunately, physicians and healthcare providers in general are paternalistic. The patients definitely do value our words. Our words hold a lot of weight, which is why the nocebo effect is real. But also, no one likes being told what to do. They don't want to hear, hey, you should go train because this. Don't just tell them to go exercise. Most people know that they should be exercising. It's not a mystery that exercise is great. Like I said, there's a huge gap in what people know is great and then what they're actually doing. The other thing I've noticed is that it's not all about body weight. So don't use just body weight centered language. There's so much more to exercise and resistance training specifically than just weight management. Like we talked on the benefits, sure, there's benefits of body composition, but there's so much more to it. And a lot of times when I hear physicians talk about it, or I've heard it in the context, there's like, hey, if you want to lose weight, you should go exercise. Every patient doesn't necessarily want to lose weight. And a lot of times if you do introduce exercise, then they're thinking, oh, this physician just wants me to lose weight, yada, yada. So I specifically myself try to bring it up in the context not of weight loss, but in the context of improving physical function. And people tend to respond much better to that. And then also, don't tell patients that exercise is easy. As much as I've said in this presentation that, or in this podcast, that exercise is easy and that it's easy to get into, it might be very, very difficult for some people. And there's a variety of barriers that may be out of people's control. And it's our role to kind of help them adapt and figure out how to get around those. And then also, once again, don't nocebo people. Don't tell them that it has to be done right to get anything out of it. Don't say things that are going to discourage them from getting involved. Our biggest role is that we should help them get involved in resistance training. And now, once again, a gentle nudge to our patients. As physicians, might be a hot take here, but I don't think we should necessarily be prescribing a workout plan. Patients aren't coming to us getting billed hundreds of dollars through their insurance to come see us for us to just write them a workout program that they can get from ChatGPT or a bunch of other free resources online. What we should be doing is avoiding the nocebo effect. We should be using positive words of encouragement to have them participate as much as possible. We should help them dispel myths about resistance training so that they can go exercise more, provide general guidance, not necessarily a specific plan. And then if they're not interested in resistance training, to find some way that they can get involved in exercise in general. Now, for those physicians who do want to do a little bit of the generalities as far as prescribing exercise, the key kind of bare bones of any sort of prescription is that number one, something is better than nothing, which we've learned from this podcast so far. Consistency is king. So it's not necessarily about doing something for like 3 months, then falling off. Try to do a little bit over a long period of time. Number three is that adaptations are not forced. And this goes back to that Goldilocks concept, which is you shouldn't do too much to try to grow. You shouldn't do too little. It's that adaptations occur over time that allow later for progression. So you can't force gains. You have to mold the program to the patient. So it's not necessarily, hey, this is a great program, you should do it. It's, hey, this is your schedule. This is a great program for you. And then if you do want to get a little bit more granular and you want to focus on the major muscle groups, those would be addressed by a couple movements: the push, the pull, a squat, a thrust of sorts, and carry. Pick one exercise from each of those, do 3 sets of 8 repetitions, do that twice a week. You are golden. That's what you're going to get as far as a basic program to reach all of your benefits. Now, once again, there's a little bit of a flow diagram here for those that are on the YouTube version. So if you're listening to this podcast, and thank you very much, we're near the end of it. If you do want to get a couple more of those visual resources and cues, then kind of go over to our YouTube channel and check out the video, especially this flow chart at the end for a doc. How do I get started? And that's it for this podcast. So I want to thank you all for listening to this. If you have been a supporter of this show, then thank you very much for that. We have a lot of great content coming out. The best way to support this podcast is by rating and reviewing it and sharing it with your friends and really getting that message of preventive medicine out there to everyone so that we can kind of grow it and then make America truly healthy again, the correct way versus whatever else is going on out there right now. So thanks. Have a great day. See you in the next episode.